Hello, everyone. Today we're going to be discussing drugs affecting blood pressure. We'll review the pathophysiology of hypertension, major antihypertensive medications, their actions, side effects, patient education, and nursing considerations for safe medication administration. Today we'll explore hypertension and the medications used to manage it. We will examine the patho of hypertension, including how changes in blood vessels, the sympathetic nervous system, the kidneys, and the RAAS system contribute to elevated blood pressure and long-term organ damage. Next, we'll identify the major classes of antihypertensives, including ACE inhibitors, ARBs, beta blockers, calcium channel blockers, diuretics, and vasodilators. We will discuss how each class works and how it helps lower blood pressure. We will also review the indications, contraindications, side effects, and adverse effects associated with these meds, as well as important nursing assessments and monitoring parameters. In addition, we'll focus on patient education and counseling, including medication adherence, lifestyle modifications, and safety precautions to help prevent complications. Finally, we'll also apply clinical judgment by recognizing cues, prioritizing care, identifying adverse effects, and evaluating the effectiveness of the blood pressure medication. And by the end of this lesson, you should be able to safely administer antihypertensive meds, educate your patients, and use clinical judgment to improve patient outcomes. Hypertension develops when there is an increase in cardiac output, systemic vascular resistance, or both. It can be classified as primary hypertension, which means it has no single identifiable cause, or secondary hypertension, which means there's an underlying condition like chronic kidney disease. One major contributor is endothelial dysfunction, which means normally blood vessels produce nitric oxide, which helps them relax and dilate. In hypertension, oxidative stress reduces nitric oxide availability, causing the blood vessels to remain constricted and increase the vascular resistance. The sympathetic nervous system also plays a role. Excessive stimulation increases norepinephrine levels, which causes the heart rate to beat faster and more forcefully while narrowing the blood vessels. This increases both cardiac output and systemic vascular resistance, which also raises the blood pressure. Over time, persistent hypertension causes vascular remodeling, where arteries, walls start to thicken and become less elastic. This stiffens the blood vessels and it cannot expand normally, leading to higher blood pressures within the arteries. Another important mechanism is overactivation of the Renin-Angiotensin-Aldosterone System, or what we call as the RAAS. This system increases vasoconstriction and promotes sodium water retention, both of which elevate blood pressure. This is why ACE inhibitors and ARBs are effective treatments. When you think about the RAAS is something that normally occurs when your blood pressure is low, when your vascular system is low, and when your sodium is low. So when there's an overreaction of it, you end up having hypertension. So finally, excess sodium intake or impaired kidney function can also cause fluid retention, which causes increase in blood pressure or blood volume. And this is how we have this issue. So the key takeaway so far is hypertension results from increased vascular resistance, increased cardiac output, blood vessel damage, RAS overactivation, and fluid retention, of which works together to raise the blood pressure. So when the blood pressure falls, the sympathetic nervous system quickly increases the heart rate and constricts blood vessels, while the RAS system causes vasoconstriction and retains sodium and water through aldosterone and ADH, all of which work together to raise the blood pressure. When blood pressure drops, the kidneys release renin. Renin converts angiotensin from the liver into angiotensin 1. In the lungs, ACE converts angiotensin 1 into angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor that rises blood pressure and stimulates the release of aldosterone and ADH. Aldosterone causes the kidneys to retain sodium and water, while ADH causes water retention. Together, these actions increase blood volume and raise blood pressure. Hypertension is sustained blood pressure, elevated blood pressure. For about 90% of cases are primary or essential hypertension, meaning there is no single cause. High blood pressure is dangerous because it damages blood vessels and organs over time. It increases the risk of atherosclerosis, stroke, heart attack, kidney disease, and vision loss. The heart must work harder to pump against increased pressure, causing the left ventricle to thicken, a condition called left ventricular hypertrophy. Hypertension is known as the silent killer because most of the people who have no symptoms don't even realize they have high blood pressure. But when they start to get the symptoms, therefore, there will be serious organ damage that's occurring. So, an important factor for nurses for a nursing assessment. Signs and symptoms of hypertension are often silent. So clients typically do not know they have high blood pressure until abnormal symptoms from organ systems begin to manifest, like headaches, oliguria, or decreased urine output, or even a heart attack, also known as myocardial infarction. Nurses performing routine screening and assessment is a key technique to help with early diagnosis and treatment of hypertension among our clients. So this is why we need to have our patients go for clinic. Sometimes it's hard for them to come to the clinic because they have other social determinants of health. So the causes of non-adherence, there's several factors that may contribute to medication non-adherence. Lack of understanding of their symptoms and poor health literacy, financial strain related to multiple medications being prescribed, unwanted effects such as headache, dizziness, and fatigue. Treatment of hypertension also focuses on non-pharmacological managements through diet, exercise, and lifestyle modifications. Sometimes you also have to think about cultural beliefs. There's a lot of patients that feel like every time they go to the hospital is quote unquote looking for something wrong. So we need to find a way to change the mind shift of our patients so that they could be able to live a better, healthier life. Clients sometimes may not be able to purchase foods that are healthier due to increased prices associated with fresh foods and healthy options, causes patients not to comply with lifestyle changes as it could be difficult to not relieve the immediate symptoms. So here are our risk factors associated with hypertension: increased age, cigarette smoking, high salt diet, high intake of alcohol, low physical fitness, obesity, insulin resistance, physiological stress, obstructive sleep apnea, family history. When it comes to hypotension means that the blood pressure has become too low. Vital signs end up being a little bit altered due to the fact that there's decreased tissue perfusion going to the brain. It can occur in the following situations. The heart muscle is damaged and unable to pump effectively. There's severe blood or fluid loss when volume drops dramatically. Impairment of the autonomic nervous system to increase cardiac output, vascular resistance, or both, or it could be related to blood pressure medications that you get that was given. Lowering of blood pressure when person sits up from lying down or standing from sitting position is considered orthostatic hypotension. It may be accompanied by dizziness, lightheadedness, nausea, changes in vision, and or syncope. Another word for syncope is passing out. Symptoms caused by decrease in blood flow is because the decrease in blood flow to the brain tissue. Increased risk is more likely in the older adults and use of medication. If you know your patient is going to have orthostatic hypertension, you advise them to get up slowly because once they get up too fast, they will feel dizzy and they are at increased risk for falls, especially the older population. All right, so like we said with the older population, which is a special consideration in children, hypertension can occur and in and is often related to underlying conditions such as kidney disease or congenital heart defects. Treatment should begin with lifestyle modifications like weight loss, healthy eating, increased physical activity whenever possible. If medication is needed, diuretics are often used first, and blood glucose and electrolyte levels should be monitored. Some beta blockers, ACE inhibitors, ARBs, and calcium channel blockers have approved PEES uses, but children require close monitoring for growth, blood pressure changes, and adverse effects. In adults, patients need education about medication side effects and when to report them. They should be taught to stay hydrated, especially during hot weathers or illnesses that cause vomiting or diarrhea, because dehydration can worsen hypotension. Lifestyle changes such as weight loss, smoking cessation, regular exercise, and a healthy diet remain essential parts of treatment. An important safety point is that ACE inhibitors, ARBs, and renin inhibitors should not be used during pregnancy because they can harm the developing fetus. Women of childbearing age should receive counseling about pregnancy prevention while taking these medications. The key takeaway is that blood pressure medications must be individualized across the lifespan, with special attention to growth and development in the children and pregnancy safety and medication education in the adults. During pregnancy, many antihypertensive medications can cross the placenta and potentially harm the fetus. ACE inhibitors, ARBs, and renin inhibitors should be avoided. If medication is needed, labetalol and sometimes magnesium sulfate are commonly used because they have a better safety profile during pregnancy. During breastfeeding, some antihypertensive medications can enter the breast milk and affect the infant. Therefore, the risks and benefits should be carefully considered. And alternative feeding methods may be needed in some situations. For our older adults, special caution is required because aging affects how drugs are metabolized and eliminated. Kidney and liver functions are often declined with age, increasing the risk of drug accumulation and toxicity. As a result, lower doses may be necessary and patients should be monitored closely. Older adults are also at greater risk for orthostatic hypotension, dizziness, falls, and syncope, especially if they become dehydrated from vomiting, diarrhea, poor fluid intake, or excessive heat exposure. Blood pressure should always be assessed before administering antihypertensive medications. The key takeaway is that blood pressure medications must be individualized for pregnancy, lactation, and older adults to maximize safety and minimize adverse effects. So, assess and check orders for parameters. So, anytime medications can alter a vital sign, it is important for the nurse to assess the client's vitals prior to medication administration. If the client's vitals do not permit the administration of the medication, the nurse should hold the medication. So, in other words, you are not going to say, oh, well, this order is due for 10 o'clock. The doctor said that this medication is due for 10 o'clock. Before you give this blood pressure medication, you must A, check the blood pressure, and also sometimes check the pulse because some of these medications could drop the pulse. So, to make sure that the patient is within the parameters of what the doctor has prescribed, you have to see if it's within the blood pressure range that is acceptable. If it's not within the acceptable range, you should hold it and notify the provider. If it is within the effective range, you need to see after giving the medication to determine medication efficacy as well as the potential for side effects of medication. The nurse should assess the client's vital signs within 45 minutes to an hour after medication administration. Other implications should focus on providing client education on the medication, its uses, and safety considerations. Even though this patient has been using this medication for years, it never hurts to see what they know and to fill in the gaps of what they don't know. The nurse should include education regarding side effects, adverse effects, and when to seek treatment. So, first, lifestyle modifications like change in diet and increased mobility is the first step to decreasing blood pressure. Before we start meds, we start with lifestyle modifications. That is step one. If that doesn't work, we'll start on meds. And the first step that they will start will be diuretics. If that does not work, then antihypertensives. Antihypertensives work to alter normal reflexes that control the blood pressure. Not all patients respond in the same way to antihypertensive drugs. So there's no one magic cure. You have to figure out which one works for the patient because of different factors and complicating conditions. That is why we need to figure out how to tailor it to specific patients. And educating them on what the side effects are will also help them understand which other medication that they should be off of or which ones that they should keep and add on to prevent them from stopping to taking the medication altogether. So we will be talking about drugs affecting the RAAS system, and those are ACE inhibitors, ARBs, aldosterone antagonists, and renin inhibitors. So remember, now that we're talking about the ACE inhibitors, ACE occurs here. ACE stands for angiotensin converting enzyme. So it converts angiotensin 1, which is not a strong hormone, into angiotensin 2. But when we say ACE inhibitors, we're stopping the ACE from happening. So it stops here. So this no longer causes angiotensin 2. ACE inhibitors all end in pril. If you see a pril, captopril, enalaprilat, I've never heard of that one, lisinopril, lisinopril, mexinopril, pril. It's an ACE inhibitor. So like I said before, originally when there's a drop in the blood pressure, the kidneys will feel it, and then it will try to release renin. Renin will go to the angiotensin area and mix together and make ACE. And make angiotensin 1. Angiotensin 1 will go into the lungs during ACE, but that is inhibited. Once it's inhibited, there is no angiotensin 2. There is no stimulation to nothing else to causing vasoconstriction or increasing the blood pressure. So this is how we find a way to stop the blood pressure from increasing. So with ACE, it acts on the lungs, it prevents. So it's here to treat for hypertension, heart failure, left ventricular dysfunction, diabetic nephropathy. Pharmacokinetics, it's well absorbed, it's widely distributed. Most of the medications are usually metabolized in the liver and excreted in the urine. Anytime you see anything extra like feces, that's when it really matters. Or if it doesn't say that it's metabolized by the liver, that's when it matters. But most drugs are metabolized by the liver and excreted in the kidneys. And a majority of drugs crosses the placenta and enter the human milk. Hence the reason why it's very difficult to maintain or to manage pregnant patients without well informing them. Here are our contraindications. Straight off the bat, if a person is allergic to something, we're not going to implement that. If they have impaired renal function, that's a concern because now the dosage could increase their risk for toxicity. Acute heart failure exacerbation, salt volume depletion, pregnancy and lactation. Adverse effects related to the effects of vasodilation and alteration in blood flow. Generally well tolerated, but you have to inform the patient that because it's affecting the kidneys, infecting the lungs where ACE occurs, bradykinin is released inside the lungs, which causes the patients to have an annoying cough. You have to inform the patient because if it bothers them too much, then we might change them to an ARB. If you don't tell the patient and they start noticing that they're coughing every time they take this medication, they'll end up stopping taking the medication, not letting us know, and we will not properly manage the patient. Another thing that could happen with ACE inhibitors are angioedema, swelling. Once they have that, you stop the medication. This also causes hyperkalemia. What should you check and where? If a patient has hyperkalemia, what should we be checking? Right. You got to check our CMP or BMP for electrolytes. Because if you already know that it could cause hyperkalemia, it's going to cause cardiac problems because hyperkalemia is actually a complication. Okay, so drug-to-drug interactions. It could interact with enalapril, NSAIDs, diuretics, and other antihypertensives, potassium supplements, because potassium-sparing diuretics keeps the potassium inside of the patient. If they're taking that on top of ACE inhibitors that increases potassium, you know it's going to cause increase in potassium, aka hyperkalemia. Check your lithium. Drugs that alter RAAS, other ACE inhibitors, ARBs, or Renin inhibitors, if they're taking others that could further decrease their blood pressure, you need to closely monitor your patient. Here's the prototype drug that we're using, captopril. Pretty much does the same thing as what I've explained. You can look at this or pause it to see what are the effects. Question 1. Please answer the following questions as true or false. The use of loop diuretics is the first drug used in the step care management of hypertension. Yeah, no. The first step is step care management of hypertension involves lifestyle modifications. A diuretic may be added in step 2. So, angiotensin 2 receptor blockers. So, what you hear here is angiotensin 2, which means it is outside of the lungs. It has reached outside the lungs because it's been converted. Anything that's a sartan, ends in sartan, is an angiotensin 2 receptor blocker. I don't know. My weird brain thinks of the R as the angiotensin receptor. Not sure if that's a thing, but that's how I remember it. But sartan, angiotensin 2 receptor blocker. So what this does, it's well absorbed. It undergoes metabolism in the liver by the cytochrome P450 system. It's excreted in the feces and urine. It crosses the placenta, and it's not known if it enters the human milk. It's not ethical to try to see if that works. As usual, if it's the contraindications is allergies, pregnancy and lactation, special considerations for those who have liver problems, kidney issues, and hypovolemia. If a patient cannot tolerate an ACE inhibitor, we will switch them over to an ARB. If the cough is that annoying, we will switch them to an ARB. Adverse effects of ARBs are headache, dizziness, syncope, weakness. They might have GI complaints, dry mouth, or tooth pain. Symptoms of upper respiratory infections and cough, not as much as they would with ACE inhibitor. They'll have a rash, dry skin, alopecia. Drug-to-drug interactions, other antihypertensive medications, potassium supplements, because this already increases our potassium, so they shouldn't be taking any other potassium because now you got to really monitor their potassium levels, check for lithiums and NSAIDs. So here is our prototype, losartan. Please pause this video to see the effects. It's the same thing as all the sartans. This one is just a prototype drug that you use. But if you see the word sartan, you know it's an angiotensin 2 receptor blocker. So when it comes to renin inhibitor, there's no other drug that we're giving you for it. This is the only one that I see. Alisecrine. Not sure if I'm saying it right, but you know how it goes. If you see it on the exam, if you see it as an option, you already know which one to pick. And in real life, if you don't know a medication, because we don't know all our meds, you're going to look it up. You're not going to say, oh, I think it looks like this. You're going to look it up. But these are the major drugs that you need to understand what they're for and what to look out for and how to educate your patients. It directly inhibits renin. So that means it goes straight to the main source, leading to decreased plasma renin, so it can't activate or inhibit the conversion of angiotensin. So it doesn't even get to the liver. It doesn't make angiotensin 1. It doesn't even go to the kidneys. It stops right there it doesn't go to the liver, the lungs. It just stops immediately from the sending cycle. So it is poorly and slowly absorbed from the GI tract, is metabolized in the liver, and it's excreted in the urine. It's all starting to sound the same. This is how most of drugs are. This is the pharmacokinetics for most drugs. All right, so the indication for use, it's approved for treating hypertension in adults and children who are 6 years of and older. So it also lowers blood pressure and reduces strain on the heart. It decreases aldosterone secretion. Contraindications include pregnancy, concurrent use of ACE inhibitors or ARBs in clients with diabetes mellitus, severe kidney problems. Like I said, it signals from the kidney. So if a patient has a kidney problem, it's not going to work. Any known allergy or concurrent use with cyclosporin or itraconazole, use with caution in clients who have dehydration or a history of swelling. Side effects are usually mild and include diarrhea, dizziness, headaches, and fatigue. Rash or cough may occur. So adverse includes hyperkalemia and angioedema, which is rare. Calcium channel blockers end in dipene, except for, I spelled it wrong, diltiazem and verapamil. So amlodipine. Faladipine, isradipine, dipine, 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 except for these two, except for verapamil and diltiazem. They are not ending in dipine. There's another name for it. As I remember what it is, I'll tell you. Therapeutic actions inhibit movement of calcium ions across the membranes of the myocardial and arterial muscles, altering the action potential and blocking muscle cell contraction. Action potential is something that we discussed in neurons. So go back to that video to see it. And if you didn't get to that video, I suggest you go into that because that's the cellular level. Indications, treatment of hypertension and angina. Why angina? Angina, whichever one you like to call it, is a vasoconstricting effect, which causes pain. Calcium channel blockers actually vasodilate. Pharmacokinetics, it's well absorbed, metabolized in the liver, and it's excreted in the urine. It crosses the placenta and enters human milk. Contraindications, as usual, allergies. This is the word that I wanted to use for verapamil and diltiazem. Non-dihydropyridine calcium channel blockers is the name of verapamil and diltiazem. So you also have to remember, first, calcium channel blockers are contraindicated in anyone who's allergic. Verapamil and diltiazem should also be avoided in patients with heart block, sick sinus syndrome, heart failure, or an acute myocardial infarction because they can further slow heart conduction and decrease cardiac output. Pregnancy and lactation goes without a given because safety must be carefully evaluated before administration. The adverse effects of calcium channel blockers are related to their ability to relax blood vessels and decrease cardiac workload. Patients may experience hypotension, dizziness, fatigue, and weakness due to decreased cardiac output. The central nervous system effects can include headache, dizziness, and lightheadedness. GI effects may include nausea, constipation, especially with verapamil. Cardiovascular effects can include bradycardia, heart block, and worsening heart failure in susceptible patients. Because these drugs dilate blood vessels, patients may develop flushing, rash, or peripheral edema. I forgot to put a picture for peripheral edema. That's pretty important. The key takeaway is that calcium channel blockers effectively lower blood pressure, but nurses must monitor for hypotension, bradycardia, conduction abnormalities, and signs of decreased cardiac output. And one of the signs would be a patient reporting, "Oh, I got swelling in my feet." You know that that should be a problem. So it's not just pushing medications to give patients. You also have to be able to talk and assess your patient. Because some calcium channel blockers affect heart rate and cardiac conduction, combining them with other medications that slow the heart, such as beta blocker and the digoxin, can increase the risk of bradycardia, heart block, and hypertension. For this reason, nurses should always review medication lists before administration. The most important drug-food interaction involves grapefruit juice. That goes with a lot of medications, but specifically for calcium channel blockers, grapefruit juice inhibits enzymes in the liver and intestines that normally break down many calcium channel blockers. As a result, drug levels can rise in the bloodstream, increasing the risk of adverse effects such as excessive hypotension, dizziness, flushing, and peripheral edema. Teaching patients are very important. Patients should be instructed to avoid grapefruit juice unless approved by their healthcare provider and inform providers about all prescription medication, over-the-counter drugs, and herbal supplements they are taking. In other words, no grapefruit juice for calcium channel blockers. Here is the prototype we use, diltiazem. Please pause the screen in order to better understand this medication. Okay, so the mechanism of action of an ACE inhibitor is the blocking of ACE from converting angiotensin 1 to angiotensin 2. What does this cause? So basically, this question is asking you what would happen if you converted angiotensin 1 from angiotensin 2? Would it cause a decrease in serum potassium levels? Would it cause a decrease in aldosterone secretion? Will it increase the serum sodium? Will it increase your serum sodium? Will it increase your blood pressure? So we're blocking ACE. What would it do? It would decrease in aldosterone. ACE inhibitors act in the lungs to prevent ACE from converting angiotensin 1 to angiotensin 2, a powerful vasoconstrictor and stimulator of aldosterone release. This action leads to a decrease in blood pressure and an aldosterone in aldosterone secretion, with a resultant increase in serum potassium and loss of serum sodium. So if you're losing sodium, you're losing fluid. And if you're losing sodium and fluid, you're at increased risk for dehydration. Vasodilators. The primary concern for this client is medication interaction between the client's prescribed hydralazine and new prescription for sildenafil. So when you think about sildenafil and Viagra, oh, I'm sorry, also known as Viagra, both these medications result in vasodilation or blood vessels. When taken together, the client should experience an extreme drop in blood pressure, which poses a risk for serious complications. So if your patient is on Viagra, aka sildenafil, and hydralazine, the nurse should consider that the client's prescribed medication, which includes both hydralazine and spironolactone, both medications work to lower blood pressure. And such, the nurse should consider this when providing education. You need to educate your patients whenever they're taking more than one kind of medication to see if they won't interact with one another. But always remember, sildenafil and hydralazine or anything that drops the blood pressure can cause it to further drop the blood pressure and the patient's at risk for harm. All right, so therapeutic actions for vasodilators. It acts directly on vascular smooth muscles to cause muscle relaxation, leading to vasodilation. Whenever you have vasodilation, your blood pressure will drop. It's used for severe hypertension that has not responded to other therapies. It's widely distributed in the body, metabolized in the liver, primarily excreted in the urine, crosses the placenta, and enters the human milk. Contraindications, known allergy, any condition that could exacerbate sudden fall in blood pressure, patient shouldn't be taking it. If the patient is pregnant or lactating, shouldn't be taking it. Cautions for peripheral vascular disease, coronary artery disease, heart failure, and tachycardia. Adverse effects would be related to changes in blood pressure or cyanide toxicity. The drug-to-drug interactions vary by individual drugs. Check each drug before use. Please pause your screen so that you can see the prototype for vasodilator. It is nitroprusside. Diuretics will be further discussed in detail in other slides related to renal. But example medications that will be used are thiazide or thiazide-like diuretics like hydrochlorothiazide, loop diuretics like furosemide, potassium-sparing diuretics like spironolactone or eplerenone, and osmotic diuretics like mannitol. So with an example of an aldosterone, which is a aldosterone antagonist, which is like a potassium sparing, which means you will have the potassium not excreted. In diuretics, most of our medications actually causes potassium loss, but as in the word potassium sparing or in aldosterone antagonist, it prevents potassium from being lost. So the mechanism of action for this is that it inhibits aldosterone, which helps the body to get rid of extra sodium and water while keeping potassium levels stable, leading to reduced blood volume and blood pressure. The effects on the body, it causes the kidneys to get rid of extra sodium and water, well, when it prevents the buildup of fluid and prevents blood pressure. Unlike some diuretics, aldosterone antagonist keeps potassium levels steady, as I said before. The primary indications are treatment of hypertension, heart failure, particularly after a recent heart attack. Eplerenone is also indicated for clients who have not responded well to other medications or who need additional medications to reach their target blood pressure. So remember before, we start with diet modifications. Then if they need to take antihypertensive, not before they get to antihypertensive, we start them on diuretics. If the diuretics doesn't work, we add hypertensive medication. If the diuretics and the hypertension medication didn't work, we might add aldosterone antagonist. We're still catering and trying to find what works for the patient. Common side effects include dizziness, tiredness, headaches, GI effects, the same usual. There's nothing out of the ordinary with this. Adverse effects is hyperkalemia because it's a potassium-sparing diet. So now you have to go back into diets of what the patient is eating that could be high in potassium for you to educate them on what not to take. Okay. Sympatholytic medications are used to treat high blood pressures by inhibiting the the SNS, sympathetic nervous system, which controls the fight or flight response that raises blood pressure. These medications are often used to treat heart disease and high blood pressure, but they can also help other conditions like urinary issues caused by an enlarged prostate, anxiety, or PTSD. Alpha-1 blockers, doxazosin, helps manage high blood pressure by blocking alpha-1 adrenergic receptors found in the smooth muscle of blood vessel walls. These medications work by calming the SNS. The effects of the body. Alpha-1 blockers help lower blood pressure by stopping norepinephrine from tightening the muscles in smaller arteries and veins. They also relax other muscles, making them useful for improving urine flow in older men with prostate problems. Indications for use. Alpha-1 blockers are medications commonly used to treat high blood pressure, BPH, and pheochromocytoma, a rare tumor affecting adrenal glands, which causes uncontrollably high blood pressures. Doxazosin is FDA approved for treating manifestations of BP and lower uterine tract symptoms. The immediate release form of doxazosin can be used to treat high blood pressure as a second choice for patients with BPH. Contraindications, as we know, allergies, pregnancy, and you gotta be special considerations for older adults and those who have a history of cataract surgery. Side effects include tiredness, headaches, fast heartbeat, weakness, swelling, nasal congestion, upper respiratory infections, breathing issues, and allergic reactions. Dose-related side effects such as dizziness, fainting, syncope, or sudden drops in blood pressure, especially when taken with other antihypertensive medication like nitrates and PDE inhibitors. These agents cause hypotension, right, and toxicity more likely in older adults. Beta blockers like metoprolol, alpha beta blockers like carvedilol will all be discussed in other medications where sympathetic nervous system or medications affecting the autonomic nervous system are discussed. Now, question 3. For which drug will the nurse need to caution patients against drinking grapefruit juice? Do you remember? It's a calcium channel blocker. And what do calcium channel blockers usually end in? When in doubt, remember what it is. Is it a sartan? No, because sartan is an ARB. Is it a pril? No, because a pril is an ACE inhibitor. Dapine? Yes, because dapine is a calcium channel blocker, except for verapamil and diltiazem. Okay. Now, whenever we're giving medications to drop the blood pressure, it could go so low to the point that we might need to give them something to increase the blood pressure. These medications are called sympathetic adrenergic agonists. Anytime you hear the word adrenergic, it's related to the sympathetic nervous system. But when you also hear agonist, that means it enhances the sympathetic part of the nervous system. Also known as vasopressors because they raise the blood pressure. Think of them as medications that will tell the body to go into fight or flight mode. They stimulate the sympathetic nervous system, causing the blood vessels to constrict or tighten, which increases the blood pressure to help improve blood flow to vital organs like the brain and the heart. These drugs are commonly used for patients who have symptomatic hypotension, meaning that their blood pressure is so low that they develop dizziness, lightheadedness, weakness, or fainting. One example is droxidopa. Droxidopa is converted into norepinephrine in the body, which helps tighten blood vessels and raise blood pressure. It is often used for neurogenic orthostatic hypotension, a condition where blood pressure drops when a person stands up. The main nursing consideration is to monitor blood pressures closely because these medications can sometimes cause blood pressures to become very high, especially when the patient is laying down. The key takeaway is vasopressors increase blood pressure by stimulating the sympathetic nervous pressure and causing blood vessels to constrict. Right? So vasopressors, these medications are often the first choice for treatment. Severe hypotension and shock when blood pressure is dangerously low. Vasopressors are called sympathomimetic drugs because they mimic the effects of the body's sympathetic nervous system. They work by stimulating adrenergic receptors. So, like I said before, if you hear the word adrenergic, think of sympathetic, such as alpha and beta receptors throughout the cardiovascular system. When these receptors are stimulated, blood vessels constrict, heart functions may improve, and blood pressure increases. This helps restore blood flow to vital organs such as the brain, heart, and kidneys. In patients experiencing shock, vasopressors do not cure the underlying cause. Instead, they help maintain adequate blood pressure and tissue perfusion while the healthcare team treats the condition causing the shock. Example, it could be an infection, blood loss, cardiac dysfunction. Common examples include norepinephrine, epinephrine, dopamine, and phenylephrine. Vasopressors mimic the sympathetic nervous system. If it's mimicking the sympathetic nervous system, it's going to increase the blood pressure and are life-saving medications used to support circulation in severe hypertension to preserve the heart and the brain during shock. Because these medications stimulate the sympathetic nervous system, many adverse effects resemble an exaggerated fight or flight response. Patients may experience tachycardia, hypertension, palpitations, anxiety, tremors, headache, and increased cardiac load. While these effects help raise blood pressure, they also place stress on the heart and blood vessels. These drugs should be used cautiously in patients with conditions that already limit blood flow, such as coronary artery disease, peripheral vascular disease, and other circulatory disorders. Excessive vasoconstriction can further reduce blood flow to vital organs and tissues. An important drug interaction occurs with other medications that increase heart rate and blood pressure, such as stimulants, decongestants, and some adrenergic medications. When combined, they can cause excessive increases in blood pressure and heart rate, increasing the risk of cardiovascular complications. Nurses are responsible for closely monitoring the blood pressure, the heart rate, cardiac rhythm. Check for tissue perfusion. You're going to check the skin to see if it's cool, if it's warm, is there adequate flow? Check for capillary refills. Check for signs of decreased circulation. All right. Midodrine is a blood pressure raising medication used to treat orthostatic hypotension, which is a drop of blood pressure when a patient stands up. Patient may experience dizziness, lightheadedness, blurred vision, and even fainting. Midodrine works by stimulating alpha-1 receptors in the arteries and veins. Think of alpha receptors as a signal that tells blood vessels to tighten or constrict. When the blood vessels constrict, vascular tone increases, which raises blood pressure and improves blood flow to the brain. Midodrine is typically used for patients whose symptoms significantly affect daily life and who have not responded well to other treatments. Pharmacokinetically, this drug is rapidly absorbed through the GI tract, metabolized in the liver, excreted in the urine. It is currently unknown if the drug enters breast milk. A majority of nurses will understand this better. Most of these medications are not for pregnant and lactating women because there was not enough studies. It was not considered ethical. A major nursing consideration in monitoring medications like midodrine is monitoring for supine hypertension, meaning high blood pressure when lying down. Because of this risk, patients are often advised to avoid taking this medication close to bedtime. Key takeaway is midodrine activates alpha receptors, causing blood vessel constriction and raising blood pressures to reduce symptoms of orthostatic hypotension. Before giving midodrine, it is important to know when the medication should be avoided and used cautiously. A major contraindication is supine hypertension, which means high blood pressure while lying down. Since midodrine raises blood pressure, it can make this condition worse. It should also be avoided in patients with pheochromocytoma. a tumor that already causes excessive release of blood pressure raising hormones. Several conditions require caution. Patients with severe heart disease may experience increased strain on the heart because of the high blood pressure. Those with acute kidney disease or renal impairment may have difficulty clearing the drug from the body. Patients with liver impairment should also be monitored carefully because the drug is metabolized in the liver. So although I keep saying liver, kidney, we're not just going to automatically just see liver, kidney. We're going to also check blood work. We're going to check AST, ALT, bilirubin, SGOT. That is for liver function. When we're looking at kidney function, you will check BUN, creatinine, and GFR. That's what's going to be. It's not going to automatically be a question where I'm going to say, oh, the liver. It's not going to always be as cut and dry like that. It's not going to be like that with NCLEX. They will give you lab values. You need to know if this is abnormal for your patient when you're about to give meds. Interactions, adverse effects. Midodrine also stimulates alpha-1 receptors, which cause blood vessels to constrict and blood pressure to increase. Because of this mechanism, most adverse effects are directly related to excessive alpha receptor stimulation. Common adverse effects are, like we said, supine hypertension, which is high blood pressure when lying down, as well as headache, goosebumps, also known as piloerection, chills, itching, urinary retention, and a feeling of pressure or fullness in the head. Patients may also experience reflex bradycardia, where the heart rate slows in response to the increased blood pressure. Several important drug interactions exist. Cardiac glycosides, such as the digoxin and beta blockers, may increase the risk of bradycardia when used with midodrine. Other alpha adrenergic agents can cause an excessive increase in blood pressure when combined with midodrine. Corticosteroids may enhance fluid retention and further increase blood pressure. Nurses must monitor blood pressure in both the standing and lying position, assess the heart rate, watch for signs of urinary retention. Patients should also avoid midodrine close to bedtime to reduce the risk of supine hypertension. Midodrine raises blood pressure through alpha-1 receptor stimulation, so monitor carefully for hypertension, bradycardia, and interactions with other cardiovascular medications. Okay, so droxidopa is used to treat symptomatic neurogenic orthostatic hypotension. These patients experience symptoms such as dizziness, lightheadedness, feeling faint, or feeling like they're about to pass out when standing up. Droxidopa works as a prodrug, which means it is converted in the body into an active substance. Specifically, it is converted into norepinephrine by the enzyme dopa decarboxylase. Norepinephrine is a neurotransmitter that causes vasoconstriction or narrowing of the blood vessel. When blood vessels constrict, blood pressures increase, help improve blood flow to the brain, and reducing symptoms of orthostatic hypotension. This allows the patient to stand and move around with fewer episodes of dizziness and fainting. Droxidopa is absorbed through the GI tract, distributed through the body, metabolized through normal catecholamine pathways, and it's excreted in the urine. So, as nurses, a key consideration is monitoring blood pressure carefully, especially for supine hypertension, which is high blood pressure while lying down. Droxidopa is converted into norepinephrine, causing vasoconstriction, increases blood pressure, and helps reduce dizziness and fainting in patients with neurogenic orthostatic hypotension. The primary contraindication, as usual, if you're allergic, why are we giving it? So this is why every time before we give any medication, we ask the patients, do you have any allergies? Maybe they forgot to tell somebody else, and you're that special one that they want to tell. You have to document. Several conditions require caution. Patients with history of cardiovascular disease, such as coronary artery disease, arrhythmias, heart failure, should be closely monitored because droxidopa increases norepinephrine levels and can increase the blood pressure and cardiac workload. Patients with renal impairment also require careful monitoring because the drug is excreted through the kidneys. What are you going to look at to check to see if the kidneys are affected? Because maybe the patient started off with good kidneys, but then over time, when we're giving them this medication, you still have to monitor it. You can't just say, oh, they were fine before. You got to keep watching because this is a progressive problem. Caution is also recommended in breastfeeding and chest feeding patients because there's limited information regarding the effects on infants. Some adverse effects are related to the drug's sympathetic nervous system stimulation. They may also have headache, hypertension, palpitations, increased heart rate, supine hypertension, and it's important for the drug interaction involves dopa decarboxylase inhibitors such as carbidopa. Since droxidopa must be converted to norepinephrine by the enzyme dopa decarbylase, medications that block the enzyme may reduce the effectiveness of droxidopa. Droxidopa raises blood pressure by increasing norepinephrine levels, so patients should be monitored for cardiovascular effects, hypertension, and potential drug interactions that may reduce its effectiveness. To conclude, hypertension is a chronic condition in which blood pressure remains elevated, causing damage to blood vessels and major organs over time. If left uncontrolled, it could lead to a serious complication like stroke, heart attack, heart failure, kidney disease, vision loss, death. Antihypertensive medications help lower blood pressure by reducing blood volume, decreasing the heart's workload, relaxing blood vessels, or blocking sympathetic stimulation. Major drug classes include ACE inhibitors, ARBs, beta blockers, calcium channel blockers, diuretics, and vasodilators. Remember that ACE inhibitors and ARBs protect the kidneys, beta blockers slow the heart rate, and diuretics remove excess sodium and water. Common side effects include orthostatic hypotension, dizziness and fatigue, while serious adverse effects may include bradycardia, electrolyte imbalances, especially hyperkalemia, and angioedema. As nurses, it's essential to assess blood pressure, heart rate, lab values, and symptoms before administering the medication. Patient education and lifestyle modifications are also critical to improving outcomes and preventing complications. The most important takeaway is that effective blood pressure control protects the heart, brain, kidneys, and blood vessels, ultimately reducing cardiovascular risk and improving long-term health. I hope this video helped. Please use this as your supplemental learning. Go back into your text, go back into your ATI or whatever modules that you need to assist with your understanding or deep dive into this topic if this is your favorite. Thank you.